All right, so we're going to get started. Welcome, everybody. Thank you all for sticking it out. Final part of the meeting here. It'll be one of the best parts for those of you who are here. And welcome people online as well. We have just a couple of quick announcements, and then I think we have a great agenda. The first announcement is Hope Foundation has a number of funding opportunities. A couple of these have been put extended deadlines because of not enough submissions. So we're trying to spread the word on this, and we've had good luck in the Lymphoma Committee of having several awards funded in the past by the Hope Foundation. So particularly early and mid-career investigators should look into these opportunities. And the other point I'd make is it's the 30th anniversary of the Hope Foundation, and we're really trying to build their ability to provide support for SWOG investigators. So I encourage everybody on our committee to consider giving. Even if it's a relatively modest amount, showing that level of participation, I think, is important for the committee, and it helps drive other people to be interested. All right. So one announcement. SWOG 1826 was accepted at ASCO for a plenary session, as well as at the Lugano meeting for a plenary session. That is thanks to many of you for your participation in that study. Hopefully you can all attend, and either online or in person, and we'll be eager to share the results at that meeting. So speaking of 1826, it's my pleasure to introduce our guest speaker, Dr. Catherine Albert. Dr. Albert got her PhD from Duke and was involved in industry in several capacities, working in particularly around oncology clinical trials. She's expressed interest in diversity, equity, and inclusion, as well as patient-reported outcomes. And she's speaking not just from that lens, but also as the lens of a patient. She has a very moving story to tell, and I think it'll be inspirational for us to all hear that and remind us all why we're here and why we do what we do. Thank you so much for coming to speak with us today.
Yes, thank you so much for inviting me. Okay, great. For the invitation to be here today, and I'm really honored to be here and to share my story as a patient in the SWOG 1826 study. So I wanted to start by introducing myself. If you looked me up on LinkedIn, this is what you'd see. I have my PhD, and I work at a biotech as a clinical research scientist. So I'm very familiar with the sponsor side of clinical trials from my professional life, designing data, cleaning, data analysis, all of that. And just a little bit about, and I've worked in rare disease. I'm currently working for a sponsor in autoimmune disease, but I've worked both in other rare diseases and oncology as well. And just a little bit about how my life was going before I got my Hodgkin's diagnosis. So I had my PhD from Duke in 2016, and I also started my career in clinical research that same year. I got married to my husband Billy in 2017, and this is a picture from our honeymoon. We went hiking at 4 national parks in Utah. It was a lot of fun. We moved to Washington and bought this wonderfully quirky house in 2018. And because a house isn't a house without a cat, we got Zena in 2018 also. So life was going pretty well at the end of 2018. Looking back, I'd say that my symptoms really started in the spring of 2019. But at the time, they were pretty generic. It was fatigue, body aches. I thought I was just too tired. I was working at a lot of trial sites in Europe, so I was up at like 4 a.m. every morning. I thought maybe I wasn't in good enough shape, so I actually joined a CrossFit gym and started some pretty intense workouts. And it wasn't until August of 2019 that I kind of convinced myself something wasn't right, and I went to my primary care provider. So with those symptoms, fatigue, body aches, and then my sedimentation rate was really high. It was actually over 120. She initially thought rheumatoid arthritis and sent me to a rheumatologist. So I was referred to a wonderful rheumatologist who started working with me in September, and she had me try dexamethasone for a while, a few other things, and eventually she wanted me to try Humira. And I was a little anxious about this. I actually pulled up the label and saw the label language in there contraindicating cancer. And at this point, I actually went back to my primary care provider and asked if we could rule out cancer before I started on Humira, and asked for a x-ray. So she referred me to imaging, and that's where we first saw my mediastinal mass. After that, things moved pretty quickly, so that was at the end of December. I was then referred to a hematologist oncologist at the local community clinic. I had my excisional biopsy and had an official diagnosis in the beginning of January 2020, and then was able to begin treatment in the SWOG trial by the end of January. So my initial diagnosis was stage 4 lymphocyte deplete Hodgkin's lymphoma. My bone marrow biopsy showed 80 to 90% involvement, various lymph node involvement, and also liver and spleen lesions, and my IPS was calculated at 4. So like I said, I was being treated at a community clinic. They were really excited to have a trial to enroll me in. So excited, in fact, that they handed me the paperwork for the trial before I had even discussed my diagnosis with my physician. So I learned I had advanced stage Hodgkin's by opening that folder and seeing the trial title. So please make sure you at least discuss with your patients first before presenting them with an ICF. The decision was to, obviously this was a big decision whether to join the trial or not. Some of the things that made my decision easier included the fact that the control arm was standard of care, so what I would have gotten anyway, so I didn't feel like there was a big risk in joining this trial. I was able to see the strong phase 2 data. I did know how to access the literature and could pull that up, as well as the approval of Nivo and other indications, so that was all very reassuring. Personally and professionally, it was kind of exciting to get to participate in clinical research as a patient and really contribute in that way. And being in the trial also allowed me to have Nivo, this new treatment, at a community clinic instead of having to travel to a research site. So from where I live in Washington State, it would be about an hour and a half travel each way to go to the Hutch, for example, and that would be the closest big research site. Some of the hurdles in my decision-making to join the trial included the fact that I adore my oncologist, but she was a sub-I on this trial, and she wasn't quite up to date, so wasn't always able to answer my questions right away. In general, the information about the trial was very much directed at me, which, as it should be, but at the same time, my husband and caregiver didn't feel as included in that conversation, and he really needed to buy into this too, since he was going to be taking care of me through all of this. At this point, I was very tired, I was very sick, and it just made critical thinking hard. So normally when I would make a big life decision like this, I would take the time to do my research, read the literature, talk to people, and I just didn't have the mental capacity to do that right then. So that felt a little scary to jump in without doing that normal amount of research. And then also I wanted to start treatment as soon as possible. Luckily, being in the trial did not delay the start of treatment, but if it had, that would have been a big consideration for me. And then the ICF, and this is, I have a lot of thoughts on ICF, and I feel like Woody in this picture here. The research coordinator was great, and she actually sat with me in a room for an hour going through this ICF. And I know that SWOG itself, each site will have its own ICF requirements and IRB requirements, so it's not that you have total control over this. But that's a really dense document, and like I said, I was really sick and tired at this time, and so that marathon session of going through this black and white text is still something I kind of shudder at, and that's something professionally I've taken back and have been really trying to make the ICFs at the companies I work for more patient-friendly. And some of the ideas that would be nice would kind of have a cheat sheet, so maybe 1 or 2 pager with the key points, and not in the same document as all the legal, I know there's all that legal language that has to be in there. Or at least more white space on the page, some figures, some tables for, I learn best visually, I know that about myself, so being presented with 26 pages of, size 12 times New Roman font is a little overwhelming. So that's just something that I've, I guess, taken on as a personal passion project, but wanted to relay those thoughts on ICF. So being in the trial, I was randomized to 6 cycles of ABD and Nivo. I look very happy in all these pictures, which, be assured, I wasn't this happy all the time in the trial, but a typical visit. So I actually was still working full-time as I was in the trial. I figured I'd rather be working and thinking about other things than sitting around and thinking about having cancer all day. So I would arrange for my infusions to be on Thursday mornings, and then I would take that Thursday, Friday off, could sleep through the weekend, and be functioning enough by Monday morning to kind of jump back into work. A typical visit would start with me obviously going to the oncology clinic. I'd meet with my oncologist. I'd have my blood work done, discuss how things have been going since the last visit, and then go into the infusion room to start my infusions. One difference was because I was in the trial, I actually met with my oncologist before every infusion, whereas standard of care, I would have met with her every other infusion, I believe. So. And really, other than that, from my perspective, really the only difference was the PROs. So I would do these in the chair, so they didn't really take up any time. I was just sitting there anyways. But a few things that I didn't appreciate at first was this fact that the PROs aren't seen in real time by the PI. So as a patient, and I thought, oh, I'm circling, I have, I don't know, acid reflux on this piece of paper, the PI is gonna know that. And that turns out not to be true, right? Because those go to the data coordinator who enter it into the database, and then the PI might never see these or might see them in a delayed fashion. So just being very clear that, if I had a symptom or a side effect, I should need to bring that up when I was meeting with the onc in my pre-infusion visit. And then the other thing that kind of annoyed me about the PROs was the recall period. So the PROs for the study had a 7-day recall period, and at least for me, the way my symptoms would work is I'd have my infusion, and then that first week would be miserable, but then by the second week, which was the recall period for the PRO, I'd be feeling better. So I never really felt like these PROs truly captured exactly what I was feeling. But other than that, being in the trial was a really painless experience. I had minimal side effects I'm very thankful for. I had some bone pain from the filgrastim, but that was managed well with Claritin. I did develop acid reflux that actually didn't really clear up until a couple months ago. Overall, my nausea was generally well managed. And like I said, I would be really fatigued 2 to 4 days post-infusion, but then would start to feel better. So after treatment, my interim PET CT showed an unconfirmed complete response and a Duval score of 1, so that was great. And then this was confirmed on my end of treatment assessment. One of the things I really liked about being in the trial is it gave me a very nice outline of what to expect post-treatment. So I'm sure you've all heard this, but after your last infusion, it's kind of like falling off a cliff because you talk to your doc, every week, every 2 weeks for months, and all of a sudden it's like, okay, you're done, see us in 3 months. And so having that outline of what to expect from the trial was very useful. I've also been made aware of the survivorship plan that is kind of more of a thing now. So that is, I guess, for me, the trial was my survivorship plan. My treating oncologist during the trial actually moved, so I was transferred to a different oncologist. And once again, being in the trial ensured that continuity of care. Up until I think January was my 3 years, so I'm now done in the trial. Overall, my physical recovery is going really well. There's still a few little things. I have some lingering back pain, which I'm always told is not chemo-related, but when I talk to the patient groups, like on Facebook, we all have it, so we think there's something there. And I don't feel like I heal as fast, like if I get a scratch or something, but overall going pretty well. And we got this giant dog. She's bigger than this now. She's a St. Bernard Poodle mix, so she's a sweetheart, but giant. Billy and I, we've taken up our hiking again and enjoying being outside. And we had a baby, so that was exciting. But even so, cancer will always be a lens through which I see life now. So some of this is hard. Like my pregnancy was really difficult psychologically because a lot of the same things that happen in cancer happen in pregnancy. You're seeing the doctor all the time, you're doing blood work, you're doing imaging, you have something growing inside of you that you're not in control of. So while physically my pregnancy went very normally, psychologically that was really hard. But then there's also kind of joyous things. So there's certain chores that I used to hate, like mowing the lawn, and I couldn't do that while I was sick. And now every time I mow the lawn, I'm just joyous that I'm well enough to do this again. And I shouldn't have admitted that because my husband's here and now he's gonna know I wanna mow the lawn. But so there's it pops up in kind of unexpected ways. But I just really wanna say thank you for all the work you do. Thank you for your work on this trial and bringing new treatments to patients. Thank you for letting me be here. And thank you for letting Leo George be here, who's in the back if you want to see a baby. So. And I'm not sure if we have time for any questions.
If I can just start, that was really beautiful. Thank you so much for sharing, and congratulations on your 3-year anniversary.
Thank you.
I think there's so many practical things that we can do to enhance the clinical trial experience and the care of patients in general. But I loved the concept of the cheat sheet for an informed consent. Can you tell us? So it's a passion. Is this something that you've started in any realm, or tell us a little bit more about that?
So I've been pushing for this in my professional life. I've had a lot of roadblocks, so it's not been easy. But right, so the way I would see a cheat sheet is maybe 1 or 2 pages that say the trial, the trial name, the trial purpose, a little schedule of events, and contact information. So pretty short, but just what the patient would need to know on a day-to-day basis, and maybe a little paragraph about potential risks, like certain side effects to look for. Another thing I've seen done and liked was a little flip chart that you can use as you go through the trial with the patient. So if you imagine it's like a triangle, right? It sits up. So on the patient side, you have a picture or a graph or something that's easily understood, and then on the side the provider's looking at, you have some talking points to make sure you talk through these things while the patient's looking at that page. So I think that is a little less intimidating than a textbook of ICF. So.
I know Hildy has a question, but I just want to say that in a lot of medical journals now, we have to do a graphical abstract.
Oh.
And I just wonder if that's something that could be added to this.
Yeah, I think that's a similar idea, yeah.
Sorry, Hildy, go ahead.
Yeah, so first of all, thank you so much, Catherine, for sharing your experience. Being the advocate on this committee for so many years, it's just incredible to hear somebody that has gone through, has had a relatively good experience, and you're through it, and now you're here, and you've got this beautiful family. And so thank you so much for sharing your experience with us. I just do want to remind that since 1826, which started many years ago, SWOG does now have simple summaries. One of the trials that we kicked off this week, 2114, it is in very simple language. It is using graphics and does have contact information for the patient, and could be adapted locally with local contact information. So I will continue to ask for your feedback because we want to make these resources more and more user-friendly for the patient. And I think for those here that are treating patients on a day-to-day basis, here we have a very educated scientist person who is working in clinical research, but we can never assume that what we're telling people is being digested and understood. So simple is always best, and clear. And people want to know what's coming next, to really give them a clear picture of what the expectation should be. So thank you so much. I've learned so much just from talking to you and hearing you today. So thanks so much.
Thank you, Hildy, and great about those sheets. Those look perfect.
Are we able to open it up so Dr. Herrera, who's online, can talk? Yes, so Alex, did you just want to introduce yourself?
Can you hear me okay?
Loud and clear.
Fantastic. I just wanted to thank you so much, Catherine, for speaking. It was really, I feel lucky to meet last summer in Hawaii. So fortunate. We are all so fortunate that you came and introduced yourself to me that day. So you're wonderful. It's really special, the patient about going through the trial that we've all so much time thinking about, and but you lived here. It was really. Thank you so much. Sorry, really sorry that either just already just in short time you've already given your thought about how we can improve the experience at all these various that we went through. Make sure that we're cognizant of the patient and make the really happening with PROs. Of course, the consent cheat sheet is a great idea. I'm confident you'll be able to do more. And but I just want you and we really appreciate your honesty today. It was really.
Thank you so much, Dr. Herrera. It felt like a celebrity meeting you at Pan Pacific last summer. So, yes, thank you for introducing me to Hildy too, and putting me on the path to be here today. Okay.
Thank you so much.
Thank you.
And we thank Leo for the special guest appearance there. All right, so now we'll start. We have 3 trials to launch today. I think that's a record, certainly for this committee. First one will be S2114. Dr. Hess.
All right, great. Really excited to have activated this study just a couple of months ago. We kicked this off yesterday. Really excited to finally activate this. This is a phase 2 trial of consolidation therapy after CD19 CAR-T for patients with large cell lymphoma and grade 3B follicular lymphoma. So just to reiterate the background on DLBCL, this is the most common lymphoma that we see in our clinics, with close to 27,000 patients being diagnosed per year in the US. The majority of these patients are actually cured with frontline therapy, but there is a large proportion of patients, about a third, that are either refractory or relapse after frontline therapy. With the second-line approvals for CD19 CAR-T for large cell lymphoma, CD19 CAR-T is now the standard for nearly all patients with relapsed large cell lymphoma, whether it be in the second-line setting or third line or greater. And so this number here is really the reason that we developed this study. Of course, CD19 CAR-T has been a huge breakthrough for relapse diffuse large B-cell lymphoma, but we still have to face that the majority of these patients eventually relapse. So the question we had when we were developing this study is, how do we identify these patients that are high risk for relapse post CD19 CAR-T? And we really think that this day 30 PET scan is a good mechanism to identify these patients. So about 50% of patients have a complete remission at that day 30 scan. About 20% of patients will have progressive disease at or before day 30, and about a third of patients will have stable disease or partial remission at day 30. Not surprisingly, if you have a complete remission at day 30, you're much more likely to have a durable response going forward. About 2/3 of this group will remain in durable response, but if you have a stable disease or partial remission, we know that the majority of these patients will eventually relapse, with only about a third of these patients having durable response. So this is the patient population that we identified as high risk for relapse. And so if we could identify this group as high risk, we wanted to identify consolidation therapies that are not only effective in treating lymphoma post-CAR T, but also safe, being that they're going to be given in such close proximity to CAR T. So a lot of the traditional therapies like cytotoxic chemotherapy post-CAR T have not shown a lot of success. So we changed our direction to look at more novel therapies such as mosunetuzumab, which is a CD20-directed bispecific T-cell engager, has a lot of promising data in relapsed large cell lymphoma. Also has the potential to augment CAR T cells in the context of this study. Polatuzumab vedotin, an antibody drug conjugate to CD79B, also approved in conjunction with many therapies, both in the relapse setting as well as the frontline setting recently. And then the combination of mosun and pola together, again, has really shown a lot of promise in relapse aggressive large cell lymphoma, with close to 50% of these patients actually achieving a complete remission. And in patients that received prior CAR T, we see those response rates are very consistent as well. So our hypothesis for this study was using mosun alone, polatuzumab alone, or the combination in these patients with partial remission or stable disease at that day 30 PET will hopefully help to reduce the risk of relapse in this group. So this study has 2 registrations, where the first registration is going to be for patients prior to CAR T cell therapy. Patients can register anytime after local consent for CAR T collection up until lymphodepleting chemotherapy prior to CAR T. Inclusion criteria is any patient receiving FDA-approved CD19 CAR T for second line or greater. So this can be liso-cel, axi-cel, or T-cell, as long as it meets the indication. For diffuse large B-cell lymphoma, follicular lymphoma, grade 3B, primary mediastinal, you can have transformed lymphoma as long as it's transformed from marginal zone lymphoma or follicular lymphoma. Bridging therapy is allowed on this trial, but you cannot receive polatuzumab or mosun. And if you do receive bridging, whether it be systemic therapy or radiation, you will have to repeat a PET scan prior to that lymphodepleting chemotherapy. One important point is that previous POLA is allowed outside of bridging therapy. We recently saw the approval of POLA in conjunction with RCHP in the frontline setting. So these patients would be allowed to enroll on trial as long as they didn't progress within 6 months of their last dose. Key exclusion criteria includes receiving non-FDA approved CAR T. So some of these CAR T cell products are out of spec, so they're received on an expanded access protocol or single patient IND, and those patients are not allowed to enroll on 2114. So again, all these patients registered to step 1 will have a day 30 PET scan, which will be centrally reviewed. And on that central review, if you have a complete remission, you're not eligible for randomization, but will stay on study, be observed, and have disease assessments and biomarker draws per protocol. Patients with progressive disease will come off and be followed for overall survival and receive physician-directed care. And then these stable disease partial remission patients will be eligible for step 2 randomization, where again, they'll be randomized to one of these 4 arms, or there'll be 30 patients per arm. Just want to highlight one of the inclusion criteria, which is having a neutrophil count of 1,000 or greater, platelet count of 75,000 or greater. Some of these patients after CAR T at day 30 can have cytopenias, and this could have excluded these patients from this trial. So we've extended the window for randomization up till day 60, when a lot of these cytopenias, have resolved. We'll be stratifying by having stable disease or PR on that day 30 scan, and receiving CAR T as second line versus third line or greater. If patients are randomized to the observation arm, they do have the option to cross over to the combination of Mosun and Pola if they have definitive progression within 1 year of randomization. Primary objective is comparing the progression-free survival of each one of these consolidation arms, Mosun, Pola, and the combination of Mosun, Pola, each one in comparison to observation, where we estimated the 1 year PFS of observation at 25%, and we'll be trying to improve that to 50% or greater for each of these consolidation arms. So in terms of the treatment that you'll get for consolidation, all the arms will be offering time-limited therapy. You see in arm 1 with Mosun, you'll have step-up dosing in cycle 1, and then be given on day 1 of each cycle 2 through 8. Pola will be given for 6 cycles, and in the combination, you have the same dosing for Mosun, and then Pola will be introduced on cycle 2, day 1, and again be given for 6 cycles. So one other really important part of this study, as we were developing it, we wanted to help refine who is high risk for relapse post-CD19 CAR T, either outside of these day 30 PETs or potentially in conjunction with these day 30 PETs. We know that minimal residual disease helps to predict the likelihood of relapse post-CAR T, but we don't have a lot of information on these different subgroups. So, for instance, stable disease or PR, obviously we're going to be interested in that in this study. But again, patients with complete remission, about a third of these patients will relapse. So we're looking to help refine who will be more likely to relapse of these patients with CR at day 30. And hopefully taking this information that we get from these subgroups could potentially lead to developing an MRD adaptive study in the future. So this is why we're going to be collecting peripheral blood draws for correlatives on all patients that are registered to step 1. So the first collection time point will be prior to lymphodepleting chemotherapy. All patients will have collection at that day 30 PET scan. And then for time points 3 and 4, for patients with partial remission or stable disease, that will be based on randomization, whereas if you have complete remission, that'll be based on your CAR T infusion. And the 5th time point will be for patients who progress after enrolling on the study. Ajay and Geeta and Hildy had done a really great job in developing PROs for this study. These will also start prior to CAR T for all patients registered to step 1. These are ready to be written into the protocol and should be written in the first revision. So again, if we're assuming that about a third of these patients have stable disease or partial remission at this day 30 PET, and about a 10% dropout rate after first registration, we estimated needing 396 patients registered to step 1 in order to randomize 120 patients. So we'll need all SWOG sites to open this trial, as well as all ECOG, Alliance, BMT, CTN. We've had a lot of cooperation from people both inside and outside of SWOG, so excited to open this up in a number of centers, and we're hoping to complete accrual within 24 months. So I just wanted to reiterate again, any patient that's getting standard of care CD19 CAR T eligible for this trial, I think this trial is really likely to be easy to enroll on for these patients. There's not going to be any extra steps for these patients to go through to enroll prior to lymphodepleting chemotherapy. We just need to make sure that they meet all of those time points, which I think all meet standard of care and have pretty generous windows. So I think when centers open this trial, they'll find it really easy to enroll patients on step 1 registration. And all of these centers will get credit for enrollment for step 1 registration. And so when I'm talking to a patient about this trial in clinic, I'll start by saying that if you enroll in this trial, nothing will change about your CAR T cell therapy, nothing will change about how we're treating toxicity related to CAR T in terms of cytokine release or ICANS. And then if you have a complete remission, which is about 50% chance, you'll have, your follow-up will basically be standard of care. You will have these imaging assessments and biomarker draws on the protocol, but really I don't expect any of these patients to have extra visits coming to the centers. And then for patients with progressive disease, again, those patients will be taken off trial, be followed for overall survival, but again, get standard of care therapies or be evaluated for another clinical trial. And these patients who are randomized or who have stable disease in PR and are eligible for randomization, again, I'm going to be talking to patients that the likelihood of relapse is much higher than staying in a durable response. So it's potentially a big advantage that they have the option of being randomized to one of these consolidation therapies and have 3/4 of a chance to being randomized to a consolidation therapy. And even if you are randomized to observation, you still have that option to cross over to Mosin and Pola. So like I said, I think this is a trial that should accrue really briskly with the centers that open it up. Happy to take any questions if anybody has questions or concerns about the logistics. But again, really excited to get this kicked off.
If you're online, please ask questions in the chat, and then we can open it up. Dr. Stiff.
Thanks, great job, Brian. As you mentioned, about 1/3 of the CR patients will ultimately relapse, and I think one of the most critical components of this is the biomarker, so hopefully we can figure out who those patients are and treat them early next study.
Great, yeah.
When we see a conventional CAR T patient now, they're in CR at day 30. We might have them come back at day 60. And then a lot of times they go back to the community centers and reports come back to us as far as what's going on. How are we going to be able to ensure that we get biomarker testing and to make sure that the scans are done when patients sometimes give us pushback saying, I'm in remission, I'm done with you guys, I don't want to come back?
Yeah, so that's a really good question. I may be a little biased here because my patients that I see for CAR T cell therapy, they can get some care locally. But if you look at this schedule for when they need to come back, I think all of these patients are coming back to the CAR T center, just looking at CR, are coming back to the CAR T center for those day 100 scans. And then they don't need to be seen back at the CAR T center for about 3 months. And I'm still following these patients for cytopenias. They're still on prophylaxis for PCP prophylaxis. They're still on acyclovir. I may be checking CD4 counts on these patients as part of standard of care. So these visits for these CR patients really mirror the standard of care for me. So if I have a patient in South Carolina that's getting CAR T and lives 2 hours away, I am still seeing them at these visits. Now, this is why we developed it this way, because I think these patients need to come back to the CAR T cell centers this frequently.
Any other thoughts on that issue? I know that there are different practice patterns out there, and that may be something that we could look at. Yeah.
Great study, Brian. We are trying to open it soon at our center as well. I just had a suggestion. So if you when we are discussing the study, if you have the curves which show that when patients get, whether it's lysocell or axicell, when they get a CR, the curves are, there's an initial drop and then it's a plateau. But PR and ST is like a pretty rapid fall, and it's like 2 months, right? So pictures, just going by the fact that pictures tell a much bigger story.
Sure.
Then if if there is some cheat sheet or something simple where, it's easy to explain to a patient that, okay, if you get a complete remission, you're going to do likely well. If you are a PR or ST, some people will convert, but most of them. And then if someone is progressive, that's different. So that might, be a quick sell for a patient who doesn't know what they're going to get, but at least feel that if they are in that group, now they have a chance of using agents which have already proven record in DLBCL and enhance their chances of getting a CR and therefore be progression free. Okay. So that was my only suggestion.
Yeah, that's a great point. I think Hildy may be coming up to speak about that.
I'm stalking you. I'm right behind you.
Maybe that could be added to the
give
plain language summary.
Yeah,
Thanks,
we
Neela.
did.
Yeah.
I spoke about it before. We did create a simple summary that does include that breakout graphically. Okay, but I would love everybody's feedback on this, that if you think it's not clear enough, or that we're missing some information that you want the patient to be aware of, please let us know. But this is available on the CTSU site, and I can give you my copy before you go to that.
Is there an issue giving that to patients? It's a
No, this particular, the simple summary, the clinic can use it to explain the trial to the patient. It also helps the trial staff understand the protocol quite simply, and it can be handed to the patient. They can
that's
take it
been
home.
IRB approved.
Yeah.
Okay. Great.
I always worry when we show Kaplan-Meier curves to people because I think it also increases a lot of anxiety. But, you know, just a thought, just to be careful in how that's framed.
All right, any other? So we're really optimistic that this will make a big difference. It's going to be up to the academic sites, I think, initially, certainly to show enthusiasm for this since they're often doing the CAR T-cell treatment.
Great, thanks.
Thank you.
Yep, thanks. Okay, so we're going to move on to our second launch. This is so exciting that we have 3 launches today. But for S2207, I'm going to ask Dr. Jennifer Amengual and Dr. Patrick Reagan to come up and talk about this. This has been a really, really fantastic effort. I just want to give a shout out to the team that has worked really well. I know Chris and Kat are here as well for all of your efforts.
Okay, well, thanks so much, Sony. And as she mentioned, this has been a really big group effort. So, you know, we have not only our statisticians, but Haider Saeed working on PROs with others, and Alexei Danilov on some of the correlative studies. So this has been a group effort, and Patrick and I will present the data. Okay, I think I'm good. Okay. So just for his way of background, and some of this Dr. Hess kind of spoke about already, so he kind of set up the stage pretty good. But the majority of patients with relapsed refractory diffuse large B-cell lymphoma aren't eligible for transplant, and these patients really represent a major unmet need. When thinking about using transplant in the second-line setting, you know, we know this historically, really only about 63% will have a response, and 25 or so % will have a complete response from traditional salvage chemotherapy. So if someone's really on the border in terms of their fitness, you might think twice about, you know, taking them through intensive chemotherapy and transplant. And even with more modern salvage regimens like polar ice, the CR rate is only about 56%. And you can see the progression-free survival with transplant really varies based on how soon after the primary treatment patients relapsed. As Brian just talked about, CAR T really has made advancements in the second line, but he also talked about that a lot of patients relapse with CAR T therapy. And those that are sort of borderline fit, you know, we also have to think about potential side effects. So CRS still occurs, you know, in up to about 40% of patients, and neurological toxicities maybe in about 10% of patients. And although in the second line, the 18-month PFS is as high as about 70 so percent, patients still may relapse. Additionally, not all patients, it's not available to all patients. They might live far from centers, might not have the appropriate caretakers at home. And so CAR T isn't really available to everybody, and not everybody's fit enough to go through CAR T therapy. We're looking a lot in this patient population, you know, for those who might not be fit for transplant, and quality of life. And quality of life, as reported by patients, has shown to be predictive of overall survival. Even in patients with relapsed refractory diffuse large B-cell lymphoma, disease control was associated with improvement of quality of life with both chemotherapy and CAR T-cell treated patients. So for part of the S2207 study, we'll focus on older patients, who aren't fit for transplant with relapsed refractory disease, who traditionally probably have been exposed to several chemotherapy lines, and this leads to a large symptom burden, both from side effects from past treatment and from the disease itself. So incorporating patient-reported outcomes or PROs are essential to measure improvement in quality of life. So thinking about these patients, we were trying to think what's a good backbone to work off of for a more frail patient population who are transplant ineligible. And thinking about the tafasitamab lenalidomide backbone, we thought that would be a good start. We were, grappling with using polatuzumab, and one of our concerns was that we thought it could be approved in the frontline setting, and now it is. And so we thought if patients were exposed to polatuzumab in the frontline, maybe that wouldn't be such a great option in potentially second-line therapy. But Tafalen, as you probably know, tafasitamab is a monoclonal antibody targeting CD19. And when combined with lenalidomide, an immunomodulatory drug, it's thought to increase ADCC through NK cell killing, lead to direct cytotoxicity, and increase ADCP as well. And in the L-MIND study, which was a phase 2 single-arm open-label study, tafasitamab was given on days 1, 8, 15, and 22 for the first 3 cycles, and then days 1 and 15 for the remainder cycles. And lenalidomide was given 25 milligrams orally, days 1 through 21 for the first 12 cycles. This regimen was very well tolerated with few grade 3, 4, or 5 toxicities, most commonly cytopenias like neutropenia, anemia, and thrombocytopenia. And then rash, diarrhea were really the most common side effects. And impressively, this combination led to an overall response rate of 60% and a CR rate of 42%. So we were trying to think, how can we build on this backbone and perhaps incorporate sort of genetic drivers of disease. So tafasitamab lenalidomide is really sort of agnostic to cell of origin. And how can we sort of incorporate some of the mutations that are known to be involved in some of these subtypes? And as you probably all know, diffuse large B-cell lymphoma, really the cell of origin has been evolving, and multiple groups now have explored gene expression profiling and found sort of smaller and smaller subclusters of diffuse large B-cell lymphoma. And these genetic subclusters do correlate with overall survival. So keeping this in mind, we tried to come up with some simple ways that would be we can target the majority of these subclusters. And as you can see, BTK inhibition could be useful in sort of the ABC subtypes, the genetic subtypes of MCD, A53, and BN2. And EZH2 inhibition could be a potential drug to target the germinal center subtype, specifically the sort of the MYC negative. And these make up the majority of diffuse large B-cell lymphomas. So thinking about these drugs, zanubrutinib, I'm sure you all know about. This is approved in many lymphoid malignancies. It's a sort of third-in-class BTK inhibitor. And in a study in relapsed refractory diffuse large B-cell lymphoma, 41 patients were enrolled. And the response rate was 29% with a CR rate of 17%. And they looked at responses based on some of the mutation patterns. And let's see if I could point from here. I don't know if I can, but on the bottom here, maybe my pointer, no. What they found was that patients who had enrichment of CD79B and MYD88 really responded even better to zanubrutinib. Importantly, this was very well tolerated, a few grade 3 toxicities, and really low incidence of rash, which was the majority of them. Tazemetostat is an EZH2 inhibitor, also approved in lymphomas for follicular lymphoma, and this was studied, diffuse large B-cell lymphoma was studied in a large phase 2 study that also looked at follicular lymphoma. And again, this was very well tolerated with 3-4 toxicities, just including 9% with thrombocytopenia, anemia, and neutropenia. And you can see in the diffuse large B-cell lymphoma cohorts, the overall response rate was about 29% in those who have EZH2 mutations. Further, this drug has been studied in follicular lymphoma in combination with lenalidomide plus rituximab, so very similar backbone to what we are proposing. And in this study, there were no dose-limiting toxicities observed, no safety signals. They found that the recommended phase 3 dose of tazemetostat was 800 milligrams twice daily in combination with R-squared. And the median duration of treatment was about 9 months. About 70% required a dose interruption, and this should say, or dose reduction. And most of that was in lenalidomide, actually, and 20% discontinued one of the drugs, most often lenalidomide. So putting that together, we are evaluating either of these drugs with the tafelen backbone. And Pat's going to take it from here.
Thank you, Dr. Amangwal. Good morning, everyone. So this is the study schema. There will be a safety run-in phase in the target population of relapsed refractory large B-cell lymphoma. The primary objective in the safety run-in phase is to determine the recommended phase 2 dose for both the novel combinations. So there will be 12 patients in a safety run-in for both tafelen, tazemetostat, as well as tafelen, zanubrutinib. We'll then move to a randomized phase 2 study. Again, same target population. And the primary objective is to compare the PFS between the experimental and the control arms. The experimental arms will not be directly compared. And this is going to be stratified by cell of origin, as well as whether the patients were refractory to their last therapy. And then patients will be randomized in a 1-to-1-to-1 fashion between tafelen, tazemetostat, tafelen, which is the control arm, or tafelen, zanubrutinib. Some key eligibility, we wanted to be inclusive of all the subtypes of large B-cell lymphoma, and so this will include follicular, this is not an exhaustive list, but this will include patients with grade 3B follicular lymphoma, high-grade B-cell lymphoma, NOS, and with rearrangements of MYC and BCL2, as well as transformed lymphoma with the exception of Richter's transformation. Patients must have cell of origin done locally using an immunohistochemical algorithm. Participants must have measurable disease, and PET scan has to be done within 42 days prior to registration. Participants must not be a candidate to receive autologous stem cell transplant. However, patients who have relapsed after autologous stem cell transplant will be eligible for the study, as well as patients relapsed after CAR T. So those patients who have progressive disease on S2114 would be great candidates for this study. And 1 to 5 prior treatments are allowed on the study. The control arm is standard tafelen, with the exception of we are giving just 13 cycles, so there's not indefinite tafasitamab. The lenalidomide is at the starting dose of 25 milligrams. So experimental arm 1, tafelen and tazemetostat. The recommended, we'll proceed with the recommended phase 2 dose for the tazemetostat, so between 600 and 800. And one of the things that I'll mention about both of the experimental arms is that the dose reductions, particularly for cytopenias, we're reducing the lenalidomide first in most of these instances, recognizing that many of these patients won't be able to tolerate 25 milligrams continuously. And then experimental arm 3, tafelen and zanubrutinib. And again, the dose of zanubrutinib will depend on the recommended phase 2 dose. The primary endpoint of the study is progression-free survival of tazemetostat arm versus control and the zanubrutinib arm versus control, again, stratified by cell of origin. Secondary endpoints include progression-free survival in the GCB and non-GCB subsets, and then response rates, non-progression rate, duration of response, other survival endpoints in GCB and non-GCB. And exploratory endpoints include to explore the PFS within subgroups defined by the molecular profile and genetic subtypes, to assess frailty using SIRS and the timed up and go, and correlation with outcome. And then we intend to compare patients longitudinally with this as well. But we're not comparing between arms. We're also interested in elucidating the immunomodulatory effects of tafelen and progression-free survival in the tafelen control arm versus a matched historical control from L-MIND and REAL-MIND studies. For patient-reported outcomes, the primary endpoint is to compare patient-reported lymphoma-specific symptoms at 2 months after randomization between the control arm and each experimental arm. Secondary include to compare patient-reported quality of life and at 3 months after randomization between the control arm and experimental arm. Secondary to compare quality of life over time between treatment arms from baseline to 12 months after randomization as measured by the FACT-LIM, FACT-G, and total score using longitudinal analysis. And then another secondary endpoint is to compare participant-reported toxicity using the pro-CTCAE items between experimental and control arms. In terms of assessments, there will be a relatively early PET scan or CTs in this study between cycles 2 and 3. The reason for that is recognizing the risk of this population and that many of these patients may progress early, and so we wanted to have uniform imaging on those patients. Additional disease assessment after cycle 6 is optional at the discretion of the treating physician. End of treatment disease assessment between 3 to 8 weeks after cycle 6, after cycle 13. And then at time of progression, PET scan for suspected disease progression, and we strongly encouraging a biopsy at the time of progression to confirm. And then with participant consent, we'll also collect peripheral blood at those time points. And for PROs, we'll be getting the FACT-LIM at baseline, 3, 6, and 12 months, and the pro-CTCAE at all cycles and end of treatment. In terms of correlatives, we will be banking samples for this, and we are interested in looking at serial analysis of circulating tumor DNA for MRD and clonal evolution in the peripheral blood. And as I had mentioned before, interested in looking at immunomodulatory effects of tafelen, looking at T and NK cell repertoire and expression of markers of exhaustion, and also looking at expression of CD19 and 20 on pretreatment, post-treatment tumor specimens and PBMCs, including whether tumor CD19 expression predicts response to tafelen. And then below are the samples that we'll be collecting, so peripheral blood and EDTA tubes, extract tubes, and then also collecting an FFPE block if possible. I know that oftentimes does not happen, or slides if one is not available. In terms of timeline, we've had final comments from Central IRB and CTEP, and these have been resubmitted. Final contracting is underway and getting very, very close, and our goal is to open in July 2023. A reminder, there will be a safety run-in, 12 patients per arm, and then moving on to the phase 2. A total of 227 patients will be enrolled, and we're estimating 6 to 7 patients per month in about 30 months to complete the accrual. And I don't know if we have time for a couple of questions, if there are any.
I think we can take 1 or 2 questions.
We'll also, I'll just mention, we'll also be doing a kickoff in the fall for the study.
The safety run-in, is it just for the 2 experimental arms, or is it all 3 arms?
Just for the 2 experimental arms.
And there's also an ongoing study that maybe one of the run-ins arms we may not need to do, so if you just want to...
Correct. For tafelen, TAZ, we may have sufficient data to skip the safety run-in.
I think this is really exciting, and like you said, it's good for, the study Brian presented, but also for people who don't have access to CAR T or are ineligible for transplant, so.
All right, thanks.
Thank you.
All right. Next, we'll take a break from the launches to go back to the future, I guess. Dr. Shadman's going to present even longer-term follow-up of 0016, and I think is gently going to use the word cure in follicular lymphoma. So this is a presentation that we will be finishing for the Lugano meeting, so we're interested in feedback from the group on this.
Thank you. It's my pleasure to present the 15-year follow-up of SWOG 0016 study entitled "The Functional Cure May Be Achievable in a Subset of Patients with Follicular Lymphoma Treated with Chemoimmunotherapy," and I'm presenting on behalf of the lymphoma group. Follicular lymphoma is considered incurable with current treatments, and despite the introduction of novel agents, chemoimmunotherapy remains the standard of care for first-line therapy. And as we try to bring the novel agents to the front line, it's important to understand the long-term efficacy and safety of chemoimmunotherapy. We reported the 10-year outcome of the SWOG, of the S0016 or 16 study, and reported a 10-year progression-free survival of between 40 to 50% and a 10-year overall survival of 70 to 80%. We also know that a biological cure may not be achievable with current treatments, but if remissions are long enough that exceed the life expectancy of the patient, considering the median age of diagnosis, which is 70, it is possible that we can provide functional cure for some patients. So with that background, we looked at the 15-year follow-up mainly for two reasons. Number one, to provide the benchmark for long-term efficacy and safety of chemoimmunotherapy. And number two, to investigate the possibility of providing functional cure for a subset of patients. S0016 was a randomized study for patients with untreated follicular lymphoma with advanced stage. The standard arm was R-CHOP, and investigational arm was CHOP with anti-CD20 tositumumab labeled with a radioactive iodine. And I will refer to that to radioimmunotherapy for this presentation. The primary endpoint of the study was PFS. And for eligibility, patients needed to have a diagnosis of follicular lymphoma from grade 1 to 3, and there was a central path review, measurable disease, stage 3 or 4, and or bulky disease defined by more than 10 centimeter. And decision for treatment was based on clinicians' judgment for this study. So the two arms were balanced for baseline characteristics, specifically looking at beta-2 microglobulin, which was a stratification factor for this study. Half of the patients had elevated beta-2 microglobulin. A quarter of patients had bulky disease, and a quarter of patients had high FLIPI risk at baseline. Looking at entire cohort, including both arms, the overall survival at 15 years is at 70%, and the PFS at 15 years is 40%. So basically, patients who receive chemoimmunotherapy as first-line therapy, 15 years later, 40% of these patients remain disease-free and alive. That's an important historical benchmark for this for chemoimmunotherapy for frontline. Now, looking at the two arms, CHOP radioimmunotherapy in blue and R-CHOP in red, the progression-free survival at 15 years was superior with radioimmunotherapy at 47% versus 34% for R-CHOP. And this was statistically significant, consistent with what we reported with the 10-year follow-up. This PFS advantage did not translate to an improved overall survival. Overall survival rates were not different at 15 years, with 67% with radioimmunotherapy and 73% with R-CHOP. And as I mentioned, there was no statistical difference between the two. To summarize what I just showed, at 15 years, we report a PFS of 34% for R-CHOP and 47% with radioimmunotherapy, with a significant difference, and overall survival of around 70% for both arms. The second aim of this study was to look at the cumulative incidence of progression, and the curve you're seeing here looks at rate of probability of relapse, and the competing variable here, or the competing risk, are deaths without progression. So patients who die for reasons other than progression in this model are treated as competing risk. And as you see the shape of this curve over time, you see that the rate of progression declines. And probably the most important point for this question of the study, if you look at the average progression rate per year, and if you look at the first 5 years and then 5 to 10 years, 10 to 15 and 15 to 20, you see that that rate drops from the 6.8% for the first 5 years to 2.3%, second time period 1.1% and 0.6%. So basically what this tells us, it tells us that the rate of progression drops over time, and that's consistent with the curve that we're seeing. And also if we separate this by the treatment arms, you see the same trend with R-CHOP and CHOP radioimmunotherapy. Blue is radioimmunotherapy, so the relapse rate is lower with radioimmunotherapy, consistent with the PFS curves that I already showed. Second, malignancies are important as a long-term outcome of any therapy, including chemoimmunotherapy. MDS and AML is reported in the first row. The numbers are higher with radioimmunotherapy, 16 patients versus 6. And other second malignancies are reported. Of course, we were interested in comparing incidence of second malignancies and also focused on AML and MDS. So there was no difference in the rate of second malignancies between the two arms, with 22.1% versus 19.7% in the two arms. But the rate of AML and MDS incidence of AML and MDS was higher with radioimmunotherapy at 5.3% versus 2.2%, although the p-value is not statistically significant, but this is a trend that seems to be at least clinically significant, if not statistically. Now, looking at cause of death in patients and separated by the two arms, if you look at the top 3 causes, number 1 is disease in both arms, and in radioimmunotherapy arm, second malignancies are second cause of death, followed by other medical issues other than cancer. The order of the second and third causes is different with R-CHOP. So the second most common cause of death are medical issues, and the third one is second malignancies. Now, we also looked at deaths because of second malignancies, and the incidence or the likelihood of dying because of second malignancies were not different between the two arms. But risk of dying from AML or MDS was higher if patients received radioimmunotherapy versus R-CHOP. In summary, we continue to observe outstanding overall survival and PFS in both chemoimmunotherapy arms, and we believe that this could serve as a benchmark for upcoming or ongoing clinical trials investigating novel agents of first-line follicular lymphoma. The improved PFS with radioimmunotherapy did not translate to a better OS, maybe because of the risk with the second malignancies in AML and MDS. And the average rate for progression decreased over time in the 4 time periods that I reported. Therefore, for a subset of patients, a functional cure could be achievable. And there are efforts ongoing within the lymphoma group to use clinical and molecular predictors to identify those patients. I wanted to thank patients and investigators. To have a 15-year follow-up, it requires a lot of commitment from a lot of people, and also the Lymphoma Committee chairs and members, the Statistical Center, and Hong Li specifically for helping us with this analysis, and also remembering Dr. Oliver Press, who was the PI of the S0016 study. Thank you.
Azir, how long is the talk supposed to be for Lugano?
I think 10 minutes? I don't know. I have to check. I'm not sure, actually.
All right.
I don't know. Did we go too
Should know
fast?
that. I do have a question that you might be asked. So how are these patients being followed? Were they getting scans on a schedule? Was it just reporting?
Yeah, so they don't get routine scans at this point, so these are clinical relapses.
And I mean, do you have a sense I guess I would potentially emphasize what the median follow-up was, that these patients were actually touched and, you know, the charts were reviewed, right?
To report the median follow-up, or how often we looked at them?
Well, I think the concern that somebody might have is that it's 15 years later and the patient moved to
Sure.
South Dakota and you never saw them again.
There's nothing wrong with So.
Yeah. So for what percentage of patients we had this kind of follow-up? Yeah, I'm sure we can have that.
Yeah, I mean, well, I think the median follow-up tells you that. If you emphasize that, I think the median follow-up here is 14 or 15 years, right?
Yeah, I think it was 14.8. It was in one of my slides, I believe.
Yeah.
If not, we have that information. Yeah, 15.5 years.
Right, so I would drive that home.
Yeah.
More than half of the patients
Yeah.
you know have been followed
Sure.
for longer than that. And so,
Uh,
They're obviously censored at that point in time. You can look at the curves, or you can see the fraction of patients.
Microphone,
So,
yeah.
I mean, from the tick marks, those are the last contact dates that we have. And so if you look at these curves, you see
Yeah.
there are definitely
Right.
patients that were lost prior to say 14 years, but the bolus of those tick marks are at least 14 years out. So it gives you a sense, as Jonathan was saying, we have there's issues with follow-up, but this is pretty good follow-up.
right.
Yeah. Just for the people on Zoom, the question was about, how people are followed and the censorship. So, but if people could use the microphones, that'd be great. Yeah.
I'll jump back in. So this figure is actually really great because it actually shows the last contact dates, and you can see the patients between, for instance, there's very few tick marks in the first 5 years. There's some more between 5 and 10, and a little bit more in between 10 and 13. And the bolus of those tick marks, the last contact dates, are patients that have at least been followed
Right.
13, 14 years.
So I'd be prepared to answer that.
Maybe
Pat?
even have a slide
Yeah.
to preemptively, address.
So should we be treating these patients with R-CHOP?
Well, that's a great question. I think, first of all, we don't know if the patients who do great with chemoimmunotherapy, they may also do great with novel agents. So that's why we do need head-to-head trials. Second, the way we monitor this patient, I think when most of the novel trials have scans built in the study, and having routine scans for indolent disease, I think that would impact your PFS curves versus just having clinical assessments. But I think at minimum, especially looking at single-arm studies that are being done in the frontline study, I think this information will help to design those studies and to help define what's success. But I don't know if we can say chemotherapy is the standard, but at least if we can define what is the subset of patients who may get to that 15-year of disease-free remission, and maybe those patients should be excluded from some of the novel agent trials. But whether or not it's R-CHOP or other chemoimmunotherapy, I think that remains to be an open question.
I would consider a couple of other ways of addressing that question. First of all, this study emphasizes the importance of long-term follow-up. Second, I think it's important to emphasize no maintenance was given here. Keep in mind you're going to be in Europe where they've been giving maintenance for years in this disease. So without maintenance, I think Pat makes a compelling point. I mean, these are data that suggest that with a standard upfront regimen, you may have cured a third of these patients with a reasonable long-term toxicity profile. So, my sense is that he wasn't necessarily jumping to new agents. A lot of people are using bendamustine. A lot of people are using obinutuzumab. There are these different regimens, and I guess you can't say from one study which is better than the other, but you can certainly say that in your mind these are compelling data that R-CHOP is an option for these patients, and that a third of those patients are likely going to be cured. The other observation I would make, and whether there's time in the talk for this, is that slide that you and Hong Li put together that looked at the risk of progression by time. So I see patients in my practice that are here for a consult or whatever, that say in year 8 or year 12 are getting their annual CT scan to kind of look for the relapse of follicular lymphoma, because it's quote unquote been a while. I mean, this is telling the patient that if you're sitting there and they're 10 years out, they have a 99% chance of not relapsing in the next year. That I don't think we would normally do imaging to look for a 1% chance. And in fact, if you started 5 years out of follicular lymphoma, this is a pretty compelling graph to speak to that. And I mean, I would suggest, particularly at that meeting where follow-up recommendations are being made for this disease, that you consider at least planting the seed in people's minds on the importance of those data. Yeah.
Great talk, really interesting data. To dovetail off of this slide, did you see that the annual incidence of death without progression increased within these time periods, one after the other? I assume the numbers are small, but that might be interesting to see sort of the opposite.
So, I mean, the dotted curve right there are deaths without progression, although the tail of it, I don't know how reliable that is, but yeah, I mean, it goes up slightly because it's 15 years, but was that your question? So the second curve is showing that information.
Yeah.
But another, aspect of that is that the cause of death, the number one cause of death remains follicular lymphoma. Like that also is something to think about. And the question is, are those deaths early? Because, every curve, we continue to see that early drop-off, that early progression of disease. Is that the population that's dying?
Yeah, I don't know.
Do we know the timing of the death from follicular lymphoma?
Yeah, we don't have a cause-specific curve, but I can't tell from the PFS or OS curve.
That might be, if you have that, of course, I think there's always, if somebody dies of an infection, did they also have lymphoma? But putting a cause-specific curve, if we could do that, might be something that would be interesting to look at.
And even overlaid in this, since you have death without progression, if there's cause-specific survival on that, of course, just more stuff, but.
But just so I understand, and I understand. So these are, this is progression. So lymphoma progression, you're thinking at a finer gradation of cause-specific?
So death from follicular lymphoma.
Death from follicular lymphoma versus death as well.
Yeah.
Okay,
right.
I understand.
And the timing of deaths because of lymphoma, we wanted to see if they happen earlier versus later.
Yeah.
Right, because you do have that also related to this story. It's the result where you see PFS is better for the radiolabeled antibody. OS is actually worse. You see that reverse. So actually the timing between progression and death is actually an interesting thing happening here as well, that presumably you have other causes of death are higher, obviously, in the radiolabeled, but also I think part of it is the timing issue between actually seeing lymphoma progression and actually observing a death. I think there's something going on there because it's pretty atypical to see. I know there's no difference here, but numerically there's a flip in the curve. And so how do you untangle that? You might get a question along those lines as well.
Just to clear for myself, if you go back to that slide progression, this is average progression rate per year.
Right.
So at 9 and 10 years, chance will be like 94%, not 99.
Or in that year. I mean, what I'm saying is if you're doing a scan at year 10, and then you're going to plan to see the patient and do a scan at year 11, that scan.
Right.
Yeah.
So you go year by year. Okay.
Yeah.
Thanks.
But I would even say that beyond scans, this could even make an argument about whether these patients belong in an oncology clinic. And, I've been referring patients back to their primary care providers. These are data that help tell the patient, why that's a good decision and, how low the yield is on seeing them once a year and checking an LDH and examining them. So I think that particularly in a manuscript, we should play that up because that's a novel contribution of these data that really the 15-year time point was important to reach. Sure. If there's time in the talk, we might be able to mention that as well.
Okay. Thank you.
Great. Thank you. So next, we're going to have another launch, this time with the SWOG Committee. We have Dr. Boyuhu from University of Utah.
So I'm here to talk about AHA 2131, which is a randomized phase 3 trial for early-stage Hodgkin lymphoma, comparing novel immuno-oncology treatments with standard chemotherapy in children and young adults. Here are my disclosures. So as we all know, early-stage Hodgkin lymphoma is a highly curable disease with excellent overall survivals of more than 90%. And these survival curves have really maintained through the years, and as we see, MOP-ABV with earlier trials showed excellent survivals of 90%. And with development of novel treatment strategies, including the more recent EORTC H10 trial, these overall survival curves have only improved for both EORTC designated favorable and also unfavorable patients. And so when we are thinking about developing new treatment strategies for early-stage Hodgkin lymphoma, not only do we need to maintain these extremely high cure rates, but the shift in the focus now is to actually reduce acute and long-term toxicities of both chemotherapy and also radiation therapy. These toxicities include infection, infertility, secondary malignancies, and cardiac and pulmonary adverse events. And so right now the standard in the US is chemotherapy with or without radiotherapy for the treatment of early-stage Hodgkin lymphoma patients. There have been multiple trials trying to reduce either chemotherapy or radiation therapy to try to reduce some of their toxicities. One of the earlier studies that was actually successful was the HD10 German Hodgkin study, in which favorable patients was shown that they could receive less chemotherapy with ABVD for 2 cycles and less radiation therapy for 20 grays, and still achieve similar outcomes to patients who received more chemo and more radiation. However, in recent years, there has been attempts to reduce or eliminate radiotherapy altogether using an interim PET adaptive strategy. And these trials, including the UK RAPID study and the H10 EORTC study, were both negative studies and that radiotherapy could not be eliminated. And so we have been trying to use PET2 to try to predict who we have to escalate or de-escalate therapy in. And PET2 has been shown to be an incredibly prognostic tool in which patients who are interim PET positive after 2 initial cycles of chemotherapy and therefore have residual disease have far inferior outcomes than patients who are in a complete remission after 2 cycles of chemo and have excellent outcomes. And so maybe we can use PET2 to de-escalate therapy in patients who are PET2 negative and then escalate therapy to rescue those patients who are PET2 positive. I'm just going to run you through a few of these trials in which we based the standard of care arms for AHA 2131 on. So the first trial was CALGB 50604. This was not a randomized study. However, patients who were PET2 negative went on to receive 2 additional cycles of ABVD and followed by no radiation. This demonstrated that patients who were PET2 negative had outstanding 3-year progression-free survival at 91%, and it has become one of the standards of care to treat patients with a chemo-only strategy for early-stage Hodgkin patients. The RATHO trial was mostly in advanced stage patients, but did include a cohort of early-stage unfavorable patients. And PET2 negative patients were de-escalated and the bleomycin was dropped so that they received 4 additional cycles of AVD. And the study conclusions were that the de-escalation to AVD for PET negative patients was non-inferior and could be implemented for early stage unfavorable patients who you wanted to treat with a chemo-only strategy. The EORTC H10 study was essentially a PET adaptive strategy to try to eliminate radiotherapy for patients who were PET2 negative. However, the elimination of radiotherapy for the PET2 negative patients was shown to be not non-inferior, but also more importantly, in the PET2 positive patients, escalation to escalated BIACOP was actually found to be superior to patients who went on to receive ABVD instead. But now in Hodgkin lymphoma, we have a lot of chemotherapy-free strategies to treat these patients in the relapse setting, including the antibody-drug conjugate brentuximab vedotin and also the immune checkpoint blockade nivolumab. And in fact, the combination has been studied together in the relapse setting, showing outstanding overall response and complete response rates, but more importantly, durable responses with a 3-year progression-free survival of 77%. So could we implement these novel immuno-oncology combination strategies in the frontline setting to reduce chemotherapy and also radiation use? And so the hypothesis of this trial is that the incorporation of immunotherapy combination of brentuximab vedotin and nivolumab will improve progression-free survival and maintain overall survival while simultaneously minimizing long-term morbidity and treatment-related mortality by reducing exposure to radiotherapy and high cumulative doses of chemotherapy. So here's the study design. Patients will be stratified according to the ERTC designated favorable and unfavorable. If they have any one of these criteria, they will be designated as unfavorable. And these include age of 50 years or greater, greater than 3 nodal sites at initial diagnosis, ESR greater than 50 if patients are asymptomatic and greater than 30 if they have any B symptoms, a maximum thoracic ratio of greater than 0.35, and bulky disease defined as 10 centimeters or greater. All patients will receive 2 cycles of ABVD followed by an interim PET-2. This will be rapidly centrally reviewed to designate whether patients are PET-2 negative or positive. PET-2 negative patients are a 5-PS score of 1 to 3, and positive is a 5-PS score of 4 or 5. Patients who are PET-2 negative at the interim PET are designated as rapid early responders, and those who are PET-2 positive are designated as slow early responders. They'll be stratified according to age, and in the PET-2 negative patients, a 5-point score of 1 to 2 versus 3, and in the PET-2 positive patients, a 5-point score of 4 versus 5. In the rapid early responders, the favorable patients will receive 2 additional cycles of ABVD, whereas the unfavorable patients will receive 4 cycles of AVD. The experimental arm is BV-nivo for 4 cycles. Notice that all patients who are rapid early responders, which we anticipate to be about 85% in the entire study cohort, will not receive radiotherapy. In the slow early responders, patients will be randomized to receive 2 additional cycles of escalated BIACOP followed by involved site radiotherapy, or BV-nivo for 4 cycles followed by involved site radiotherapy. The primary aims of this trial are to show superiority of 3-year progression-free survival in favor of the immuno-oncology approach in both the rapid early responders and the slow early responders. Key secondary aims include to demonstrate non-inferiority of overall survival at 12 years. Key inclusion and exclusion criteria, this will include ages 5 to 60, newly diagnosed untreated early-stage Hodgkin lymphoma patients, and patients must have adequate organ function, including an ejection fraction of 50% or greater, DLCL of 50% or greater predicted. Exclusion include nodular lymphocyte predominant Hodgkin lymphoma, patients with history of active interstitial pneumonitis or interstitial lung disease, as both brentuximab and nivolumab may cause pneumonitis. Prephase steroids are allowable until cycle 1, day 1, and peripheral neuropathy greater than grade 1 at the time of enrollment, given that patients may be randomized to receive brentuximab. So some of the study takeaways. This is one of the largest studies designed for early-stage Hodgkin lymphoma with an anticipated 1,875 patients screened and 1,782 eligible. The majority of patients will avoid radiation, given that we predict about 85% of patients will be PET-2 negative, and all of these PET-2 negative patients will not receive radiotherapy. Really, only a minority of patients will receive escalated BIACOP, which is anticipated to be about 7.5% of the entire study population, or 134 patients total on study. And again, patients only receive 2 cycles of escalated BIACOP. And currently, these novel agents, brentuximab and nivo, are not available for treatment in the frontline setting for early-stage Hodgkin patients. And so this is really the first time that we're able to employ these novel agents in combination as a chemotherapy-free strategy for frontline early-stage Hodgkin lymphoma treatments. This study activated at the end of last month, and we are eager and excited to have you all on board. So I just want to acknowledge the entire study team that had a lot of input from radiation oncology, radiologists, and we have an incredibly strong PRO and correlative study group, which I did not get into today due to time. So I'm happy to take any questions.
Boyu, just going back to the schema, so for the rapid early responders, do they end up getting 6 cycles of anthracycline right here, like the
just for the unfavorable patients.
The unfavorable.
Mm-hmm.
Mm-hmm. Okay. All right. I guess I hadn't remembered that, and it's just okay. Any other questions at all? This is really exciting. We've already had patients asking about it. We're so close to opening it, so yeah. Thank you. Great.
And it'll be open for a while, I think, right?
5 years.
Yeah, it'll take a while. I think it will take everybody, but the success of working with the pediatric groups for S1826, I think bodes well for this. So, really great job. Okay. So, do you want me to?
I think
Yeah.
the order got changed around, so this is going to be rapid fire. We'll just ask when the next slide, because everybody just has one slide to review. When the next slide comes up, if that speaker could come up, it'll be, I guess, pay attention. And maybe introduce yourself when you speak, because it's not all the same as in the book, because some people weren't able to make it.
Hi, everybody. My name is Debbie Stevens, and I'm at University of Utah. And I wanted to remind you about the S1925 study, which is actually a study run through the leukemia group here at SWOG. This is the EVOLVE study, and it is specifically designed for newly diagnosed patients with CLL who are asymptomatic and do not have cytopenias, so those patients that would standardly be put on a watch and wait program. These patients need to be high risk, and they need to have a CLL IPI score of 4 or higher and or have complex cytogenetics. And for this study, we define complex cytogenetics as 3 or more abnormalities on their karyotype. These patients are being stratified by high risk versus very high risk. So a high risk score is an IPI of 4 to 6, or very high is 7 or more. These patients are being randomized 2-to-1 to early venetoclax and obinutuzumab therapy for 1 year versus delayed therapy. And delayed therapy would start at a time when you would standardly recommend treatment for those patients, so they develop symptoms or cytopenias. Our primary endpoint of this study is overall survival, and in order to do this, we need all of your help to accrue 247 patients. At this time, we have accrued 64 patients, so that's about 25% of the population, and so we're really making a lot of progress, but could really use help to find all these patients. You can see the secondary endpoints and translational endpoints that are listed here. I'm also going to be presenting on behalf of the study chair, Dr. Paul Barr, the S1608 study. This is a randomized phase 2 study in early progressing follicular lymphoma. Early progression is defined as progression within 2 years or refractory to bendamustine or CHOP-based therapy. These patients are being stratified by using maintenance therapy, lack of CR, or early progression of disease. And as you all likely know, this study was put on hold for quite some time because of the umbralisib arm and umbralisib being taken off the market for this indication. However, the study is open and running, and the 2 arms that the patient could be randomized to are lenalidomide and obinutuzumab, which is a 12-month treatment, or they could receive chemoimmunotherapy with obinutuzumab. And if they receive bendamustine in the front line, they would receive CHOP in the second line, and vice versa. The primary endpoint of this study is CR after 6 cycles by PET-2 or by PET-CT. And primary translational objective is going to be validation of the M7 FLIPI in this high-risk population. So the study was put on hold for a little while, and so some of you may have forgotten about it, but just wanted to remind you this study only needs 21 more patients to fully accrue. And so if you do have this study open, please keep your eye out for these patients.
So 2 important studies. I think I'll just put a plug in for 1608, because that was closed for about a year, and I could easily see how that could leave people's minds, but this is still a very compelling question, and in addition to the clinical question, we're getting samples from these patients to really understand the dynamics of early progression and new targets. So we really just need everybody to participate. Hildy?
Yeah, I just have a quick question about the CLL study. I don't know where Debbie went. But I know that there was discussion as it was being developed about patients possibly not wanting to, that would rather not be treated, or had, the worried well that did want to be treated. Do you think that's impacting accrual at all, or there's no not enough experience yet.
I really think the biggest thing that has impacted accrual on this study was COVID, just because these patients, obviously would not have been treated, and so, adding something in that might increase their immunosuppression and thus risk for COVID, I think that was a really big deal. I find that when I present this study to patients, people are much more likely to enroll if you just talk with them at the very beginning. You say, hey, we're going to check these risk factors, see if you have high-risk disease. If you don't have high-risk disease, great. We're going to do watch and wait. If you do have high-risk disease, then we have this trial to offer for you because it may be that early treatment would benefit you. But I think, sometimes we have a year to enroll patients from diagnosis. And so sometimes if a patient's already been on watch and wait for like 9 or 10 months, and they come in and they're like, well, I kind of already got used to this idea, so I don't really want to do it. But so when you really first meet the patients, I think is the best time to bring the study forward.
I think a big advantage is the time-limited therapy, because for high-risk patients in particular, that's not always an option with, a doublet, for example. So that's another big plug.
Yeah, and the drugs are provided by the study, whether the patients are on the early or delayed arm. So, it kind of guarantees that the treatments are going to be paid for as long as you follow this treatment regimen on the protocol.
And it's important to build into your workflow when you meet a patient with CLL the investigation of these risk factors, which may not be done if somebody's asymptomatic. And we've learned that there are more of these patients potentially out there than you would think, particularly in the older patient age group.
Yeah, it should be about a third of all newly diagnosed patients, if you look at the numbers. Thanks.
All right, next we got this one. Oops, sorry.
It's okay. Hi, so I'm Liz Bram. I'm the study chair for S1918, and so we were on hold for a little while, not quite as long as a year. So just to remind everybody, this is our randomized phase 2-3 study of our mini-CHOP with or without oral azacitidine for our older patients, which we defined as 75 and older, with diffuse large B-cell lymphoma. So we started this study with a 40-patient safety lead-in. We have now, we went on a safety pause the last time that we presented this in the fall. We have now completed our safety pause. So we are now open to the regular phase 2 accrual. For the short term, for the next 40 patients, we are going to continue to have a monthly safety call based on some discussions we had with CTEP, but otherwise we are in the randomized phase 2 component. You can see there it's 130 subjects, so we have a ways to go before the next pause. There will likely be an amendment relatively soon, but for now you can continue enrolling patients under the current version of the protocol. And just a thank you to everybody who has this open, because actually we've only been reopened for about a month and we already have 5 accruals, which is really, really exciting. So please continue to keep this in mind for your older patients, 75 and older.
Just repeat the randomization again.
So it is our mini-CHOP with or without oral azacitidine. And there is a pre-phase. At this point, the pre-phase is steroids only to make things a little bit simpler for people, but also so that you can get some sort of treatment going while you're getting everyone enrolled and randomized.
So 75 and up. Think about this.
Sign them up.
Sign them up. Great. Thank you.
That's not.
No.
Hello, I'm Nilanjan Ghosh from Levine Cancer Institute, and I'm presenting this on behalf of Dr. Manali Kamdar. And so with this study, this is the study in primary mediastinal large B-cell lymphoma. So this is, I'm sorry, let me just get my glasses.
I think we're all in the same boat.
So for newly diagnosed primary mediastinal lymphoma, the physician decides initially whether it's going to be treated with dose-adjusted R-EPOCH or with R-CHOP plus radiation or with R-CHOP. So this has to be pre-decided. patients are allowed to get one cycle of treatment initially, and then they are randomized to get either 3 cycles of chemoimmunotherapy or 3 cycles of whatever chemoimmunotherapy they've chosen, plus PD-1 inhibitor, in this case nivolumab. And then they get interim PET scans, and depending on the response, if they have basically either got a CR, PR, or SD, then they get, for chemoimmunotherapy, they get 3 additional cycles. If they got chemoimmunotherapy plus the PD-1 inhibitor, they get 3 additional cycles of that. So total 6 cycles, then the end of treatment. If they're progressive disease, they come off therapy. If they're complete response, then and they have chemo alone, then they continue with observation. If they had pre-decided that it was R-CHOP plus radiation, then they get radiation. For partial remission, which is for those with partial remission, chemo alone, they continue observation, or they may choose to get a biopsy. If they choose to get a biopsy, they would, and it's positive, then they get radiation. If it's R-CHOP plus radiation is what they had initially decided, and they get a PR, then they basically get radiation. For stable disease, chemo alone, they come off therapy. For R-CHOP plus radiation, they get radiation. So the current status of this trial, sorry. So, oops. There you go. So the current status, accrual updates, 74 enrolled. They require 186 evaluable patients, and the expected rate is about 50 per year. The estimated time to complete the accrual is 3 years. So here are the accruals based on the different cooperative groups listed over here. There are no major toxicity signals which have been seen.
Can you remind us when it opened again? Do you know? The 74, was that, it took like maybe 2 or 3 years to get there?
That was my question for Manali.
Oh, okay.
I don't know for sure when this opened.
Great. Okay, thank you.
Okay, thank you.
Yeah.
Hi, I'm Brian Till from Fred Hutchinson Cancer Center. This is the ECOG trial for mantle cell lymphoma to see if patients in MRD negative complete remission can be spared an auto transplant. So they get any induction, get restaged, get MRD tested. Those who are an MRD negative CR, which is about 80% of patients, get randomized to an auto transplant with 3 years of rituximab maintenance, or just the rituximab maintenance without auto transplant. Everybody else stays on study and just gets a standard auto transplant at rituximab. The study has accrued pretty well, and we actually met the original planned goal for the randomized portion of the population. However, a snag was that quite a few patients who were particularly randomized to the transplant arm basically refused their assigned therapy, and that was actually 16% of patients, and so that kind of messed up the statistical power, so we had to consider what to do in that situation. The good news was that we hit a higher number of randomized patients than we were anticipating based on the MRD negativity rate being higher than we thought. So we were kind of ahead of the game in terms of the total planned patients. So we've kind of decided that we're just going to stick to the original planned number of patients, which will actually hopefully end up boosting the randomized population by another 100 patients or so, which works out to actually work out pretty well in terms of preserving the power to kind of correct for the non-compliance. One possible kind of threat to this study is the publication or the presentation of the triangle study from the European group, where some centers have interpreted the data, somebody could argue prematurely or not, to stop doing transplants in mantle cell lymphoma. I think most kind of academic centers, I think, are still doing this and still feeling comfortable offering a transplant to patients in first remission for mantle cell lymphoma, but the accrual rate has dropped off a bit since that publication. So we're hoping to, if we can boost that number back up to about 12 patients per month, which is where we were about a year or two ago, then we can wrap up the study in about a year. So that's kind of our hope. I'll leave it at that, unless we want to talk more about triangle or anything.
Yeah.
People have any reactions to that triangle in the, I mean, are people still comfortable enrolling patients on this study? Anybody want to speak against that?
Has anyone stopped offering transplant? Maybe show of hands.
Well, I think considering the short follow-up on triangle study, which is still only 3.5 months, and it's unpublished, ibrutinib is no longer approved for treatment of mantle cell lymphoma. It is not known whether you can extrapolate triangle results to other BTK inhibitors. I think it's still a great study for standard risk MCL, not for complex karyotype or P53, but for standard risk for sure. That's my opinion.
Very well said.
All right, so we're hoping maybe another year or so, you're thinking?
Yeah, I mean, if we stay at 6 to 8 patients per month, it may be closer to 2 years. But if we can push that up a little bit, it'd be a year.
All right, I think that's the last one. Did anybody else have slides that somehow we didn't include, or anybody else want to say anything? I do want to just take a minute to acknowledge Hildy Dillon, our patient advocate, who is retiring from this role after a term-limited period of tremendous service to the SWOG Lymphoma Committee. We really thank you for all the work that you've done, and I think you even showed today the contributions that you're making.
Thank you. So thanks, everybody. This was fantastic. Have a safe trip home, and we'll see you. Oh, sorry.
You go ahead.
So, of course, Hildy is not going to leave us without some support and a wonderful new partner. So Tricia Hernandez is our new patient advocate. We are thrilled to have her join our committee. We got to meet her a little bit yesterday in our closed session, but she brings with her a tremendous amount of experience from the Leukemia and Lymphoma Society and is also a survivor. And we're really grateful and look forward to working together. Welcome. And so with that, I will wish everybody safe travels home. Hope to cross paths at ASCO, Lugano, or definitely in the fall. Take care.